Okay, let's move on to a question. The following will be effective in homozygous familial hypercholesterolemia except colesevelam, mimipirsen, ezetimibe, and rosuvastatin. Good for you. You chose rosuvastatin. Now, this is a question that medical students are always getting wrong. They always get it wrong because they assume that rosuvastatin is really powerful. But remember, statins are definitely going to require aggressive, normal LDL production. So let's move on to the second question. What is the mechanism of action of ezetimibe? Is it A, a blockage of the enzyme that produces intracellular cholesterol? Is it B, increased synthesis of PCSK9? Is it C, increased uptake of luminal cholesterol in the bloodstream or into the bloodstream? Is it D, inhibition of intestinal cholesterol transport proteins? Or is it E, reduction of the calcium slow current? Good, you chose D. So D, inhibition of intestinal cholesterol transport proteins, reduces the level of LDL in the blood. A is incorrect because blockage of an enzyme that produces intracellular cholesterol, that's a statin. B, increased synthesis of PCSK9, that's actually no drug. The PCSK9 inhibitors act as immune modulators or immune globulins that attach to PCSK9 and prevent it from doing its job. C is wrong, increased uptake of luminal cholesterol into the bloodstream, that almost doesn't even make any sense. And E, reduction of the inward calcium slow current, is wrong. They will do that to you because sometimes they'll get you confused with a cardiac drug that sounds similar. So pay attention to the drugs that you're using. Okay, let's go on to a question again. A 55-year-old male has elevated LDL cholesterol. He was started on rosuvastatin 10 milligrams daily. His current medications include perindopril for hypertension, aspirin, and fenofibrate for severe hypertriglyceridemia. What do you think the most appropriate strategy is going forward? So what should we do? Should we stop the fenofibrate as there is a very high likelihood of a fatal drug interaction? Should we reduce the fenofibrate dosage as there's a potential for a fatal drug reaction? Should we continue fenofibrate but monitor liver enzymes and follow closely? Or use a higher dose of rosuvastatin and continue the fenofibrate? I think that's reasonable. Continue fenofibrate, but monitor liver enzymes and follow closely. Remember that a combination of fenofibrate and rosuvastatin has a very low risk of that really horrible fatal interaction, possibly in the 1 in 1 million range. So to stop the medication of the severe hypertriglyceridemia in order to start a statin is not a rational choice. It might be what your patient wants to do, but it's not rational because there's not a real tangible risk other than that theoretical risk going forward. Monitoring and being careful is the best way to do this. Okay, that's it. I hope you enjoyed the lecture and good luck on your exams.